Well, thank you very much for that kind introduction. It's a real honor to be here. I've been in the VA system for about 23 years, and I have worked with many people here in the audience. And it's funny, I talk to them all the time on the phone or by email, and sometimes when we see each other, we wonder, are you so and so? And it's kind of odd, but I tell all my colleagues that one of my perks working at the VA is that I work with physicians across the nation. And I learn from each and every one of them. I learn a lot of things, and I have that advantage too with many of the transplanters that might be just work in a city or are kind of limited. And I have the blessing of working with people from all over the country. The other thing I want to say before I start is that, in a sense, I think I'm talking to the converted here. I'm preaching to the converted because the support that we had from all the physicians in the VA has been fantastic. Our numbers, our transplant numbers, continue to go up, and not only with other hematologic malignancies, but specifically with myeloma. So, with that in mind, I'm going to give you my talk and try to convince you that there's still a role for transplant in the era of new agents. My disclosures: I am in the Speakers Bureau for Sanofi, where I deliver non-branded talks. I have research support from Otsuka and Merck, and I'm a consultant for Spectrum Pharmaceuticals. I'm going to talk about off-label indications for almost all the drugs here because, as you know, many of the drugs that we use every day, even in first line, do not have an indication for that. So I'm disclosing that up front. Now, for the crowd over 50 here, I don't think there are very many, we'll remember this publication in the New England Journal. It's hard to believe, it's 1996. And that was the first study, came from France, that showed, that demonstrated that transplantation was superior to what we call conventional chemotherapy. But you have to keep in mind that at that time, the transplants are very different than what we do today. Number one, they use bone marrow. They didn't use peripheral bloods, which is essentially what we use 100% today. They use total body radiation, which is, as you know, very difficult to tolerate, especially in patients with myeloma. And these patients were submitted to interferon maintenance in both arms. As Dr. Ribeiro alluded to, the drugs that they had at that time weren't the most active today by today's standards, but it clearly showed that transplant was superior to conventional chemo. And you will also recognize those two curves. Both there was a superior event-free survival as well as survival. It took seven or 8 years to have a second report in the New England Journal of Medicine that essentially showed the same thing, that both in this case, overall survival was superior than conventional chemotherapy or standard therapy, and also the progression-free survival favored the transplant arm. And you might wonder, at least I did, when I saw this second article, I said, well, rarely do you have the same topic covered in the New England Journal of Medicine, basically showing the same thing, especially such a long time apart. And the reason to me is that, I'm sure you have heard this, but transplant is like religion. You either believe in it or you don't. And despite that first study that was fairly powerful, it took a second transplant a second report in the New England Journal of Medicine to really establish this modality in multiple myeloma. Now, after it was established that transplant was able to confer longer event-free survival and survival, the natural question is, when is the best time to do this? Or probably more appropriate is, can we wait a little to do this and still get the same benefit? And there's a lot of reasons to consider that. The first one is what these ladies and gentlemen alluded to. It's very hard for a patient sometimes to accept that they have myeloma and willing to be transplanted fairly early in the disease. As you well know, many of these patients have to travel. Many of them have to make arrangements, financial or otherwise, before they can go to a transplant center, especially in the VA system. And it's a very valid question. I think it was a very valid question. And again, the French help us to answer the question. And the short answer is yes. There's benefit. Your patient can still benefit from a transplant later in the course of the disease. And this is illustrated here. You see the overall survival and event-free survival are pretty similar. But probably more important than that is, in the patients that were transplanted earlier, this area under the curve, this twist, the area under the curve is larger when the patient is transplanted earlier, meaning that this twist, which is time without therapy, symptoms, or toxicity of therapy, is longer when you transplant the patients up front. It's funny, I was giving a talk a couple of days ago to a group of residents, and I asked them if anybody knew who Chubby Checker was, because when I saw this twist, the first thing that came, nobody knew. So I felt like a dinosaur, but I think there's a couple of people that know who Chubby Checker is. So, but the other thing I want to tell you about this study is that it has been, to a certain extent, misinterpreted, because you've probably seen this curve many times, but what they don't show you is probably the flow of patients on that clinical trial. And it was very, very straightforward. They followed the patients very closely. And as you can see here, these patients had a collection quickly after therapy. They were divided in two groups, early transplant versus late transplant. The patients that were assigned to the late transplant, if they did not respond very quickly or had progression of the disease, had salvage chemo and went to transplant rapidly. The same thing with patients that benefit from chemotherapy initially. The minute they relapse, they receive salvage with this combination, which is not something we use very often today, and quickly went to transplant. And that's how you need to interpret that study, that you can wait, and you can give them conventional treatment, but as soon as the patient relapses, you have to move them to transplant right away. And I think this has, with all these drugs that we have today, that has been interpreted as, well, later is later. So it could be 1 cycle, 2 cycles, three lines of therapy, and then take them to transplant. And that's not what this study showed. What this study demonstrated is that if you follow these patients closely, quickly upon relapse, if you move them to transplant, give them salvage and move them to transplant quickly, you have the same benefit. So I try to explain this to the trainees because, these things get, by word of mouth, and few people recall the details of this very important study. Now, you're all familiar with these drugs. I'm really sorry that I could not hear the first speaker because it's a challenge. I wanted to see what he said in terms of treatment. Okay, well, I'll be on the first line here trying to see, but it's a major challenge for all of us. What is the best treatment? Is it the same for a different type of population, or how do we approach this? I think if I go around the room, we're going to have very, very many answers, probably many of them correct. And you saw the NCCN guidelines, how many possible combinations it had there. So I'm glad I wasn't asked to cover that topic, but I want to remind you these are excellent drugs that have prolonged the life of many people, But also they have their problems. I think people say, well, transplant is toxic. I might want to wait a little bit, and it is. It is a toxic therapy. But also, there's a fair amount of toxicity with these drugs, including our nemesis basically has been peripheral neuropathy. And many of these patients that come to us late, they really have very, very, very severe neuropathy that during the transplant process, it is my impression they get a little bit worse, but quickly improve. The other thing, you're very familiar, the vein thrombosis. I think we have learned to deal with that very well. But there's other problems with new medications that we'll need to monitor and take into account when we make a decision about how we're going to treat patients, not only first line, but salvage. Now, many of you will recognize this study, which is pretty much taught us a lot of things that we do today as part of our practice. This was an ECOG study that was very simple when they designed it, like good trials should be. Basically, they gave the patients 4 cycles of lenalidomide, and the difference between the two arms was the amount of steroids that they got. It was a high dose versus a low dose. And as you probably remember, this study had to be stopped earlier than what they planned because the high dose steroid arm had a lower survival than expected. It was a wide difference. They stopped the study early. And basically, the study established Revlimid and low dose therapy as the way you should be giving this drug up front. And actually that has, as you know, has extended to other drugs too, the low dose of steroids. But they also did something very clever with this study. Basically, they look at all the patients 3 years, what do they call a landmark analysis. They did an analysis 3 years after the study started because the patients had 3 options. It was a very liberal protocol, basically, where you can stop therapy. Remember, this is several years ago. We didn't know many of the things we know today, but the patients were given the option of stopping the chemotherapy. They were given the option of going to transplant if they elected to do that, or they were able to continue therapy at that time. And again, this is not randomized. This was done after. This is a post hoc analysis, and it showed that, not surprisingly, if you did not get any therapy, the median survival at 3 years was around 55%. Okay, if you continue with the conventional chemo, again, not surprisingly, your median survival at 3 years was about 79–80% when you combine these two curves. On the other hand, if you underwent transplant, your overall survival was 91%. So again, these people were not randomized through these arms, but it's a good way of looking at a group of patients that were initially uniformly treated and then given several options. So I think this tells you, even with these new agents, there's benefit after transplantation. Also, there's been another study that I'm sure you're familiar. It taught us a big lesson. And the big lesson is, do not interpret data until it is fairly mature. The problem we have today in myeloma is that we have lots of agents that are very good. We're trying to learn quickly which one are better, and we report these trials very early. And that can be grossly misleading, especially in a chronic disease like myeloma. And I think this study is a very good example of that. This was again, in this study, the patient underwent induction with 4 cycles of lenalidomide and dexamethasone. And their consolidation, so to speak, was melphalan, and lenalidomide, or they underwent an autologous transplant just like we do these days. That hasn't changed more, 200 milligrams per meter square divided in 2 doses. And the primary endpoint of the trial was progression-free survival. And this study is done by Palombo, which is one of the best, in my opinion, myeloma investigators. And he reported this 1 year after the trial started. And probably shouldn't be a big surprise, but the progression-free survival at 1 year was exactly the same, 91%. But the following year, he also reported the study, and it was dramatically different. At 26 months, these have changed. And now the progression-free survival favor the transplant arm 73 to 54, although the survival was similar. So we're still, as far as I know, this study is still ongoing, and we don't have all the final numbers, but myeloma is a chronic disease, and when you look at studies, you have to be careful how to interpret things and take into account the time of follow-up. And actually, it's kind of, it's weird, but this was one of the first studies that show that in the era of new agents, there's still a progression-free survival advantage, and we're still following those patients. The toxicity was higher in the transplant arm. That also shouldn't be a surprise. The grade 4 neutropenia was almost universal in the transplant arm. Infections, less than 20%, but they were present compared to 0. And the GI toxicity was around 21%. One thing you need to remember about transplanting is we have evolved greatly since that first study from Atal. And the mortality today of patients with myeloma, I think in all the transplant centers in the VA, it's probably between, we tell the patients between 1% and 2%. And you know the type of patients we treat. In reality, I was looking at our database recently, and the last patient we lost due to treatment-related mortality really was probably more than 5 years ago. Why? Because we know the toxicity of these drugs. We make sure that that patients are prepared. We optimize their medical care. And melphalan is a fairly gentle drug for to be given in high doses. So the mortality of these patients is really very, very low. Now, I'm not going to tackle this. I'm going to let Dr. Kaufman tell us how he treats myeloma at diagnosis. But the reason I put this slide here is to remind you that when you see a patient with myeloma, you have to decide pretty early in the course if the patient is a transplant candidate or not. The fellows in our program now, and many of the local referring physicians, they're not going to make me mad if they say, hey, Dr. Freytes, this patient is not a candidate for transplant. And that's perfectly okay. These are patients that are old, have many comorbid illnesses, and I understand that perfectly. What bothers me a little bit is that patient that was not a transplant candidate, and my team back there can tell you it's true, all of a sudden, after given 58 lines of chemo, becomes a transplant candidate. and that I really don't like it, because not only have you exposed that patient to a lot of side effects, but the benefit of transplant in that setting is not very good. To do a transplant to get 6, 7, 8 months of benefit, I don't think it's worth the time of the patients traveling, all the toxicity, all the effort. So you need to make early in the course a decision if this patient is a transplant candidate. Now, who is eligible for transplant? I mean, that's what that we vary a lot in people think that we want perfect patients, and we really don't necessarily none of us have perfect patients. The first thing I'm going to tell you, in our center, age is not a criteria, okay? So we do not use age as a criteria to exclude people from transplantation. And you all know why. Because you can see a patient that is 70 years of age and is in perfect health. And then we have a 45-year-old that has all these comorbid illnesses that might not be a candidate. So age, at least we do not exclude people just solely on the base of age. Basically, performance status is important. If you have some of our 70-year-olds, they go to the gym, they run, they have these lives in which they have taken care of themselves. And you just look at those patients and you know that these patients are probably going to be very good candidates. Patients on dialysis, I'm very glad to hear that story because we've been doing those patients for a long time, and many of them have been like this. They have greatly benefit. There's one patient, he didn't do very well, I have to admit, but had a long remission and basically forced us to do a second transplant because he said, this is the only prolonged remission I ever had. And unfortunately, he derived like a year of benefit, but you have to be careful. We can treat those patients with the support of our nephrologists, and they do very well. Always consider the patient's psychological and social circumstances. It's a tough disease to handle. You're away from home. Your life can be complicated by financial issues, by other social issues. So make sure that this patient is really able to go away from home for 6 weeks and be stable. I think our patients, we treat them very well, and I tell people our job is not for them not to be nervous when they come, but when they leave. We want them to feel that it was worth their time and their effort to come and see us. And I think that's almost uniformly the results. So I think, again, make a determination of eligibility early in the disease. Now, everybody here is familiar with the concept of complete deep remissions resulting in better disease-free survival and overall survival. And that's great to know. But I want to remind you of two things. Number one, this is a function of the therapy you give, but also of the sensitivity of the disease. And I'm going to show you a couple of slides from a study that hasn't been published, unfortunately. I think they need to publish these very quickly because it has very important conclusions. And basically, when is the best time to transplant a patient? We really don't know. We base our practice in some studies, but is it after, let's say, 4 cycles? Or is it after you attain a certain depth of response? That's really an unanswered question. And Robbie Bish from Washington University tackled this question, I think, in a very clever way. And also, he addressed the issue of the patient that does not attain a deep response after, let's say, 4 cycles of treatment. We all see those patients. With these drugs, you get a complete response or a near complete response very quickly. 2-3 cycles, most of those patients are there. But there's a group of patients that don't attain that response. Should we continue treating those patients, or should we just go ahead and send them for transplantation? And this is a clever way to look at this. He used the database of the CIBMTR that has thousands of patients. And he said, I'm going to look at the patients that had less than a PR. I'm going to see the people that went directly to transplant. The doctor say, let's send him to transplant. He had enough chemo even though he never attained a PR. Or people that say, I'm going to try to attain that deep response and then send him to transplant. And this is the first 12 months after diagnosis. And kind of as a quality control, he looked at all patients. These are all patients. And of course, the progression-free survival and overall survival was inferior to patients that had less than a partial remission after induction. But in the patients that had less than that PR, the key question is, do they benefit from further therapy, or do they just benefit just sending them to transplant? And you can see part of the answer here. The treatment-related mortality and the relapse was similar between both arms. And the things that you're probably more interested, progression-free survival and overall survival, were pretty much the same. So the take-home message is, if you have a patient with myeloma, you're giving them 4 cycles, 5 cycles of chemo, and the patient, you want to get him into a deep response, which is commendable because of the curves I showed you earlier. But those patients are telling you, we don't respond that well. Many of them go into deeper responses, but at the end of the day, the overall survival and progression-free survival is the same. So keep that in keeping that in mind in your practice, because we get a lot of phone calls about that, and The only thing I tell people is if the only patient that I don't want to bring right away is a patient that is progressing. That patient we know they don't really benefit. But if the patient they attain less than a PR, you gave them adequate therapy, let's say 4 cycles, I think we need to move those patients to transplant early. Maintenance. You know that there's good data from the U.S., ECOG again, showing that lenalidomide after autotransplant results in higher progression-free survival, very evident from the beginning of the study. Took a little bit longer to realize that there was a survival benefit, okay? And initially, so, you know, when they reported these studies, the survival was not significant. So life would be easy if there were no problems with this data. But the major issue here has been the second cancers. There are higher second cancers in patients that receive lenalidomide, 8 versus 1 hematologic cancers, and 10 versus 5 in solid tumors. And that has scared many of you with good reason. Okay, many of these diseases, these leukemias with antecedent hematologic conditions like myeloma, they're very difficult to treat. The mortality is high, and many of these tumors are not treatable. So I don't think everybody has embraced maintenance for everybody. The argument of Dr. McCarthy and Dr. Palumbo is that you have to look at the big picture. And the big picture is these are second primary cancers. In the placebo, there's very few. With lenalidomide, there are more. But when you look at the disease progression and death, the patients that underwent lenalidomide, the death is much lower than placebo, and the disease-free survival favors the disease progression favors greatly the lenalidomide arm. So if you're going to have a patient that has a progression-free survival of 23 months versus 41, do you worry about a 5% increment in tumors, 4 to 5%? And that's a tough question. I don't think I have the answer, but I think you have to evaluate each patient and come up with a reasonable alternative and discuss it with the patient. I think that is important because that data is there, and these patients need to know. Also, you have to remember that there's a French study that hasn't shown any survival advantage with maintenance with lenalidomide. So I think the VA, in many visions, the pharmacy committees are not very excited about maintenance. But it's something, but if you request a drug, they will provide it in most cases. So it remains an open question. I think if this study becomes positive, it's going to be easier for maintenance to become like the standard. Show you this slide from 2013 to tell you that be prepared to hear a little bit more about conditioning regimens getting better. This one is using bortezomib before, as part of the conditioning regimen, and after as a consolidation. And there's some benefit, especially in patients that have less than a VGPR. Unfortunately, survival has not changed very much, but in patients with less than a VGPR, it seems to help them. And lastly, I want to talk to you about second transplants. We do a lot of these, okay? And this is because these patients all relapse. Now we have a lot of patients that can receive all this drug and also receive a second transplant. And this is a summary. It's a slide from Donna Reese. Our series is here by Juliana Bursinski when she was with us. And as you can see here, you get the responses are decent. Can be from 50% to 95%. These are different population of patients. And the median overall survival after a second transplant is basically fairly decent too. Again, different population of patients. But it's a very viable alternative, and we actually harvest for two transplants. These slides, just to remind me, use the patients that benefit the most is the patients that are transplanted, that the second transplant takes place after 2 years of remission. If you have to pick and choose, that will be the magic number. Although we're doing an increasing number of patients with 1 year because we had a protocol to treat those patients, an investigational protocol. But it looks to me after many years of doing this that 2 years is the magic number. So what are my recommendations? Assess transplant eligibility quickly, diagnosis, harvest enough stem cells to transplant. Try to transplant patients early in the course of the disease. There's nothing magic about 4, but it's a good number. It gives you time to submit this paperwork that you hate to bring the patients to the center and discuss post-transplant maintenance with patients and give recommendations based on each patient's particular situation. You know that there's very different group of patients. And I want to show you this final slide. Don't see transplant and chemotherapy as competing entities. Okay, I always hate that. I'm a chemotherapist, I'm a transplanter, I'm in between. We're all oncologists and hematologists. We're not one or the other. And for every patient, you have to decide what's best. And the good news is you can see here how the impact of all these upfront drugs has had in transplant if you use both modalities. And look where we were a few years ago. Remember, Dr. Ribeiro told you about BAD? Well, that's BAD here, okay? And this is using a combination of the active agents. So hopefully we'll make this disease a chronic illness like hypertension, diabetes, and we can manage these patients for many, many years with a decent quality of life. Okay, so again, thank you for your kindness in inviting me, and I'm really honored to see so many friends here, and I hope that we continue working together. Thank you so much.